Hey everyone, how's it going? Today I'm going to be talking about radiation therapy and um, ways that we can kind of potentially mitigate stochastic effects and negative outcomes from radiation therapy. This video is going to be based on an article that I recently had published, and so I wanted to kind of dive into some of the content that the article discusses and talk about the conceptual framework. Um, Radiation therapy is, of course, one of the most important tools that we use in modern cancer treatment. It's used to destroy malignant cells, shrink tumors. It can also be used to preserve organs, relieve pain, and overall improve survival outcome and survival rates for people who have cancer. Um, as great as radiation therapy is, it has several fundamental clinical challenges. The same energy that we use in radiation therapy can also damage healthy tissue. Even when two patients have similar cancers and receive similar radiation doses and therapies and are treated in a similar way using the same equipment, they can often experience very different outcomes. One patient might tolerate treatment very well and have relatively mild side effects, while another could develop severe inflammation, fibrosis, organ dysfunction, or other long term complications. Why does this happen? Um, my article explores some of the reasons why this happens and some of the ways that we can improve outcomes through genetics. More specifically, the article considers how inherited genetic variation, tumor specific mutations, radiation dosimetry, clinical history, and emerging gene modulation technologies might eventually be combined to make radiation therapy more individualized to the patient. The central idea isn't that genetics should replace conventional treatment planning. It's that instead, genetic information may eventually become another layer of clinical evidence that helps physicians identify patients who are unusually sensitive to radiation. That can be used to predict which tumors may respond well and develop better strategies for protecting normal tissue. Um, to understand the framework, we first need to understand how radiation damages biological tissue. Ionizing radiation or high levels of energy transfer, excuse me, high levels of ionizing radiation can transfer enough energy to disrupt atoms and molecules. It damages cells through both direct and indirect mechanisms. Direct mechanisms are where damage occurs when radiation deposits energy into DNA or near DNA into other molecular structures. This can create damaged bases or base pairs, as well as damaged crosslinks. It can cause single strand breaks and double strand breaks. Double strand breaks are especially vital because both strands of the DNA, both of the phosphodiester backbones in the DNA molecule are severed or broken. If these breaks aren't repaired correctly, the cell can lose its ability to divide, it can lose the ability to enter programmed cell death. Um, it can enter programmed cell death or it can undergo mitotic catastrophe, where it basically lyses and spills all of its contents. Indirect damage occurs primarily through radiolysis of water, where the water is being energized. Because the body contains a large amount of water, radiation frequently interacts with the water molecules and generates reactive oxygen species, ROSs. These include hydroxyl radicals, superoxides, and hydrogen peroxide. Reactive oxygen species, they can damage DNA, proteins, lipids, mitochondria, the cell membrane, and they can also contribute to inflammation and long-term tissue injury. The cell attempts to respond through a network of damaging or damage sensing proteins, various checkpoint pathways, antioxidant systems, and DNA repair mechanisms. The most important of these are the homologous recombination and non-homologous end joining systems. Homologous recombination is generally more accurate, but it requires an available DNA template, and it's limited to particular phases of the cell cycle. whereas non-homologous end joining is faster and it's more broadly available, but it can introduce errors while reconnecting broken DNA ends. And the effectiveness of these pathways really differs among individuals and among tumors. So, a tumor with defective DNA repair may be highly sensitive to radiation because it can't recover from treatment induced damage. In contrast, a tumor with strong repair activity, increased antioxidant capacity, altered apoptosis, or severe hypoxia may be more resistant. Normal tissues also differ in their ability to repair sublethal damage between radiation fractions. So, this biological recovery is one of the reasons radiation is frequently divided into like multiple treatments rather than being delivered as one large dose or at one time. So, radiogenomics or genomics examines the relationship between genomic variation and patient's response to radiation. So, in this context, we're interested in two different genomes. The first is the tumor genome. Tumors acquire mutations that can influence cell cycle control, DNA repair, oxygen metabolism, apoptosis, signaling, and treatment resistance. And these molecular characteristics may help determine how effectively radiation kills the tumor. The second is the patient's inherited or germline genome. Inherited variants may influence how healthy tissue detects DNA damage. It can influence how the body neutralizes oxidative stress, regulates inflammation, repairs cellular injury, and regenerates after treatment. um, Genes and pathways commonly investigated in radiation response include the ATM, ATR, BCR81, BCR82, um, RAD51, XRCC1, ERCC1, ERCC2, TP53, and components of non-homologous end joining. Other relevant systems include antioxidant and mitochondrial defense pathways involving S0D2, GPX1, glutathione metabolism, and NRF2 regulated transcription, inflammatory and fibrotic signaling involving transforming growth factor beta, um, interleukin 6, tumor necrosis factor alpha, and NF kappa B may also contribute to late tissue injury. And then hypoxia related pathways include HIF1 alpha and VEGF signaling and may influence tumor resistance and vascular response. Um, However, my article emphasizes that radiosensitivity should not be reduced to a single gene. A radiation response is complex and polygenic and highly dependent on context. So, a genetic variant may have a modest effect on its own, but become more important when combined with other variants, a particular dose distribution, an underlying medical condition, or exposure to chemotherapy. For this reason, the article proposes pathway level analysis and multivariable risk modeling rather than single gene determinism. So, a proposed clinical framework. Um, would divide radiation treatment into three broad phases: pre-treatment assessment, treatment planning and delivery, and then post-treatment surveillance. So before treatment, clinicians could combine tumor sequencing, selected germline assessment, baseline organ function testing, medical history, previous cancer treatments, and the expected radiation dose to nearby organs. Patients could then be placed into general categories such as standard risk, elevated risk, or a very high risk for normal tissue toxicity. Very high risk patients might include individuals with inherited DNA repair disorders, cancer predisposition syndromes, previous radiation to overlapping areas, or tumors located near particularly sensitive organs. Importantly, genetic risk would not determine the radiation dose by itself. Instead, it could change how clinicians weigh existing treatment options. For example, consider a patient predicted to have an elevated risk of radiation pneumonitis during treatment for lung cancer. The information might support the use of more conservative lung dose constraints, adaptive treatment planning, proton therapy when appropriate, and avoidance of additional lung toxic therapies when feasible, as well as closer monitoring after treatment. Similarly, a patient with inherited cancer predisposition syndrome may require careful consideration of whether radiation can be avoided or replaced with another effective treatment. The framework is therefore not about withholding curative therapy simply because a genetic marker suggests increased risk. Um, it is about using genetic or genomic information alongside established clinical evidence to improve the therapeutic ratio. So the therapeutic ratio represents the balance between controlling the tumor and limiting injury to the healthy tissue. So protecting normal tissue through gene modulation is probably the most experimental portion of the article, and it examines whether healthy tissue could someday be temporarily protected at the molecular level. So this idea raises an immediate concern, of course, and any therapy that increases DNA repair, antioxidant activity, or cell survival could also contradictory protect cancer cells. So it could weaken radiation treatment or permit genetically damaged cells to survive. Therefore, an effective radioprotective intervention would need to satisfy several conditions. It would need to be tissue specific, tumor sparing, temporary, measurable, and carefully timed. One theoretical strategy would involve transiently supporting DNA repair and cellular stress response pathways in normal tissue. This could involve enzymes associated with base excision repair, single strand break repair, DNA ligation, polymerase mediated repair synthesis, mitochondrial antioxidant defense, or inflammatory resolution. The purpose would not be to make healthy tissue permanently resistant to radiation. The goal would be to improve recovery during the interval between treatment fractions. However, persistent or systemic enhancement of repair pathways could be dangerous. It could protect tumor cells, preserve cells containing harmful mutations, or produce unintended long term effects. So, a second possibility involves plasmid or episomal expression systems. A plasmid is a small piece of DNA that can be introduced into a cell to produce a selected protein. Episomal systems can potentially provide temporary gene expression without permanently integrating into the chromosome. So, in theory, these systems could deliver radioprotective factors to tissues at high risk of injury. Examples might include protecting oral mucosa during head and neck radiation, salivary glands during treatment of oropharyngeal tumors, lung tissue during thoracic radiation, or intestinal tissue during pelvic radiation. One pathway of interest involves manganese superoxide dismutase, also called MnSOD or SOD2. This enzyme helps convert damaging superoxide radicals into less reactive molecules. Plasmid liposome systems involving SOD2 and related superoxide dismutase mimetics have been studied as possible radioprotective or radiation mitigating approaches. A third theoretical strategy involves recombinant viral vectors. So viruses can be engineered to deliver selected genes into cells. Compared with plasmids, viral vectors may provide more efficient cellular delivery, but they also introduce additional risks. And these risks include immune reactions, unintended gene expression, insertional mutagenesis, excuse me, with integrating vectors, prolonged expression, and accidental uptake by tumor cells. And so, for that reason, viral delivery would require extensive preclinical testing and carefully controlled early phase clinical trials. None of these gene delivery approaches should be interpreted as established standards of care. However, there are research directions intended to ask larger question. Can we protect healthy tissue from radiation without protecting the tumor? And confounding there are going to be confounding variables and scientific limitations, of course. So genetics represents only one component of radiation response, right? Tumor type, tumor stage, tissue oxygenation, vascularity, immune cell infiltration, metabolic activity, and the tumor microenvironment can independently influence treatment response. Patient specific factors are also important, so age, smoking, diabetes, autoimmune disease, infection, nutritional status, body composition, baseline organ function, and previous radiation exposures may all affect toxicity. And then treatment related factors, including total dose per fraction, radiation mobility, motion management, image guidance, concurrent chemotherapy, immunotherapy, surgery, and targeted medications can all affect outcome. So even the definition of toxicity, right, can vary among studies. So some investigations focus on physician-reported complications, others use imaging, laboratory biomarkers, or patient-reported outcomes. And follow-up periods may also be too short to capture complications that emerge many years after the treatment. So another major limitation is population representation. A genetic risk model developed primarily in one ancestral population may not perform equally well in another. Without diverse research participation, precision medicine could produce inaccurate predictions and widen existing healthcare disparities. And the article therefore recommends prospective registries, standardized toxicity scoring, patient reported outcomes, serial imaging, long term biospecimen collection, and the integration of genomic, radiomic, immune, clinical, and dosimetric information. So, ethical considerations. Genetic testing also raises ethical and logistical questions. Patients must understand whether testing examines only the tumor or also evaluates inherited DNA. Germline testing can uncover information that affects not only the patient but also biological relatives. It may reveal an inherited cancer predisposition syndrome or another medically significant finding that was not the original focus of testing. And this creates questions about informed consent, genetic counseling, privacy, data security, insurance implications, and access to results. And there's also the risk of unequal access. So, if radiogenomic testing and advanced radiation technologies are available only through major academic centers, precision radiation oncology could deepen existing disparities. Excuse me. So, responsible implementation would therefore require clear consent standards, access to genetic counseling, representative research populations, transparent clinical thresholds, and equitable availability of validated testing. Well, in conclusion, the central message of my article is that the future of radiation oncology may involve a more holistic form of precision medicine. Radiation treatment is already highly personalized in its physical delivery, and clinicians use imaging, computerized dosimetry, intensity modulation, stereotactic techniques, adaptive planning, brachytherapy, and particle therapy to shape radiation around a tumor. And the next step may be to personalize treatment according to biology as well as anatomy. Genetic profiling may eventually help identify patients who are more likely to experience severe toxicity, tumors that are especially sensitive or resistant to radiation, and normal tissues that require additional protection. The most realistic near term application is not a single genetic test that dictates treatment. It's a validated multivariable model that combines genetics with dosimetry, imaging, medical history, organ function, tumor biology, and patient reported outcomes. More experimental strategies such as transient DNA repair, plasmid or episomal gene expression, and recombinant viral delivery may eventually provide another layer of normal tissue protection. But these technologies must be developed cautiously. The objective is not to simply repair more DNA or make every cell more resistant to radiation. The objective is selective protection, preserving healthy tissue while maintaining or ideally improving tumor control. Achieving that balance will require prospective clinical validation, tissue specific delivery systems, and diverse patient representation, ethical safeguards, long term monitoring. Radiogenomics offers opportunity to make radiation therapy more precise, not only in where radiation is delivered, but also in how each individual patient is biologically prepared to respond.